It's after the hour, so I'm going to start. Good afternoon, everyone. Shaun Goodman here, one of the associate heads of the Division of Cardiology, one of the cardiologists. I'm covering the highlights from the American Heart Association for those who weren't able to attend. This is my lengthy list of potential disclosures / conflicts, and I have some relationships with some of the companies for some of the therapies that I'm going to be discussing. So as always, take what the speaker says with a grain of salt. So the overarching objectives are to review some key presentations in the cardiology space oh, that's interesting. That's an old slide. It should say the American Heart Association Scientific Sessions 2024. I'm not going to cover off the AHA 2023 nor the ESC 2023. Apologies. And so we're going to talk in particular about some highlights from some of the late-breaking science that was presented at AHA 2024, which will cover off a broad category of cardiology-related topics. I'm going to start off with a case. I won't get you to vote, but I want you to think a little bit about this particular scenario. So a 64-year-old woman who's had hypertension that's long-standing. She has type 2 diabetes. She has dyslipidemia and obesity. She had a non-ST segment elevation myocardial infarction with some transient heart failure a couple of years ago, was found to have some quote-unquote mild obstructive disease, but fairly diffuse. No coronary revascularization was undertaken at that time because she had a relatively preserved left ventricular function, and there was no significant major epicardial obstructive disease to revascularize. So she's being seen in the office and a bunch of medications. I'm just listing some of the relevant cardiovascular, cardiometabolic treatments that she's currently on. She has been monitoring her blood pressure at home, and her blood pressure ranges systolic somewhere between 126 to 134 over 74 to 86 millimeters of mercury. So the question on the table is what systolic blood pressure target would you aim for in this individual? Would it be where she currently sort of sits somewhere between 131 to 140 / 121 to 130? Or would you specifically target to 120 millimeters systolic or below to aim for her blood pressure control? So this is one of the questions that was raised by the BP Road study out of China that was presented in the first late-breaking science session a couple Saturdays ago in Chicago at the American Heart Association. What is the optimal systolic blood pressure sort of target or threshold in individuals who have hypertension and type 2 diabetes? Just by way of background, you're probably all well aware of the fact that meta-analyses of randomized clinical trials suggest in general, and including in patients with diabetes, that there are cardiovascular outcome benefits, heart outcome benefits, for example, lower risk of stroke and other cardiovascular events, with a more intensive lowering of blood pressure below, for example, 140 systolic and 90 millimeters of mercury diastolic. We know that this is in part from the SPRINT trial, reminding you that over 9,300 patients who were at increased cardiovascular risk, but without diabetes, were randomized to an intensive versus a standard systolic blood pressure sort of target or threshold, i.e. below 120 in the intensive arm was the aim, versus the standard, making sure that on average the systolic systolic blood pressure was below 140. And this was indeed associated with a significant lowering of major adverse cardiovascular events, including all-cause mortality. But as I mentioned, in the SPRINT trial specifically, those with known diabetes were excluded. Now, going back many years ago, as part of a 2x2 factorial design that also looked at the use of statin and LDL cholesterol control, the ACCORD study in just under 5,000 patients with diabetes was undertaken, and they randomized patients also to a strategy to get a systolic blood pressure below 120 as a target versus the sort of standard of care, at least at that time, below 140 millimeters of mercury. In the ACCORD trial, there were no significant differences in cardiovascular events or mortality. But I think it's recognized that this trial was likely underpowered, in part reflected by the fact that the primary outcome in the control group was around 2% per year, whereas the sample size estimation and the treatment effect was predicated on a 4% per year cardiovascular event rate. There are a couple of more recent trials, including the STEP study that was published in the New England Journal in 2021, and the ESPRIT study that was just published earlier this year in The Lancet, that took, again, a randomized approach to a more intensive target achievement of systolic blood pressure. Those individuals in the STEP and ESPRIT trial included at least a subgroup of several thousands of patients who had diabetes. And interestingly, the subgroup analyses specifically suggested that regardless of diabetes status, there was a significant reduction in cardiovascular events when one targeted a lower threshold, for example, below 120 or below 130, depending on the trial, millimeter of mercury systolic blood pressure target. So that's the background. In other words, there is no dedicated current trial of a more intensive versus standard systolic blood pressure threshold in patients, in this case specifically with type 2 diabetes. And so the Chinese BP Road group took individuals who were 50 years of age or older, had type 2 diabetes, had hypertension with an elevated systolic blood pressure, and randomized them to the intensive treatment group versus the standard treatment group. And you can see the targets to try to get the systolic blood pressure in the intensive group below 120 millimeters of mercury versus the standard group trying to achieve systolic blood pressure below 140. So the definition of having an increased systolic blood pressure varies somewhat dependent on whether the patient was more recently diagnosed and or taking antihypertensive medications or not. And the definition of elevated cardiovascular disease risk is outlined here. I won't go into the details, but fairly standard as, for example, a history of known diagnosed cardiovascular disease or known subclinical cardiovascular disease, or risk factors, or having chronic kidney disease defined as an eGFR between 30 and 59. And so these patients were randomized and then followed up monthly at the mainly hospital-based outpatient clinics across China to try to get them to their randomized strategy, a target threshold. And then once that was achieved, they were followed up with in-person visits every 3 months. So patients were enrolled between February of 2019 and December of 2021. Some challenges, of course, during the pandemic, with some loss to follow-up that I'll outline a little bit later on. These are some of the selected baseline characteristics. I won't go through the details. Certainly with over 12,000 patients, almost 13,000 patients randomized, as you might expect, the characteristics are evenly distributed in the intensive treatment and the standard treatment group. But just to characterize the patient population, they're on average a mean of about 64 years. There's a good proportion of individuals who are 65 years and above. You can see that the starting blood pressure is around 140 over 76. Pretty good female representation, 45%. The duration of diabetes is around 10 years since the time of diagnosis, and then a smattering of individuals who have either clinical cardiovascular disease or subclinical cardiovascular disease or chronic kidney disease. Most of these individuals, unsurprisingly, were on antihypertensive therapy, and at the start, on average, about 1.5 antihypertensive therapies before being randomized to the two treatment threshold target strategies. And you can see the different antihypertensives. You can see some of the so-called antihypoglycemic therapies listed, and at the very bottom two rows, the use of concomitant statin and aspirin therapy. So this is a look at, over the course of time, the initial systolic blood pressures and then the mean achieved and the median achieved in the standard and the intensive treatment group. I think the most important thing is that while the 140 target group did on average meet their threshold relatively early on and maintained that, you can see that getting to below 120 millimeters systolic in the intensive treated arm it was not, on average, easily achievable. And yet there's a big differential, of course, in absolute terms between the standard treated group with respect to their blood pressure and the intensive treated group. And at the very bottom, you can see, let me just get my laser pointer going here. You can see the contrast between the standard treatment group that pretty much stayed on about 1.5 antihypertensives over the course of time, compared to the bottom row there, the intensive treated group that got upwards of 2 and 2 and change. So there was definitely an increase in the utilization of antihypertensive therapy. And from the supplementary table and the simultaneous publication in the New England Journal of Medicine, you can see that all antihypertensive therapy increased and all the different classes increased to be able to achieve this reduction and a mean or a median in the ballpark of the 120 that was the intensive treatment target. After the first year, we're told from the paper that approximately 60% of patients in the intensive treated group actually met the systolic blood pressure target. So that means that just over half were able to get below the intensive threshold of 120 millimeters of mercury. So here's the primary outcome, which is a composite of non-fatal stroke, non-fatal myocardial infarction, treatment or hospitalization for heart failure, or cardiovascular death. And over a median follow-up of just over 4 years, and you can see in the small print, they lost some to follow-up, including from the pandemic, some withdrew consent, and perhaps the most remarkable figure there is that only 152 patients, apart from those that dropped out or withdrew consent, actually stayed in the study but discontinued therapy. So overall, sort of less than 10%, were not adhering to the two treatment threshold arms. So that's pretty good sort of follow-up and, as best as can tell, adherence to the two treatment strategies. And in that context, you can see that there are almost 500 primary events in the standard treatment arm in blue, as compared to almost 400 events. And you can see the annualized primary event rate in the intensive treated group. So that corresponds to a 21% essentially relative reduction in the primary composite outcome experienced by the intensive compared to the standard treatment group. I won't go through all the details. They're in the New England Journal of Medicine, but directionally, all of the components of the primary outcome were numerically in favor. These are annualized, and you can see the hazard ratios. Not all of them are statistically significant, but stroke was, and that was the most frequent event of the primary composite outcome. So you can see that all of the events were at least numerically in favor of the intensive treated arm. And then all-cause mortality at the bottom, again, not statistically significant, but numerically lower in the intensive compared to the standard treatment group. All the pre-specified subgroups showed consistent benefit of an intensive compared to standard treatment approach. In terms of the downsides of intensive treatment, comparable serious adverse events, and really only symptomatic hypotension and hyperkalemia were statistically more frequent in the intensively treated group compared to the standard treatment group. But I'll point out that particularly for hypotension, symptomatic hypotension, out of 6,000 and change patients, we're talking about 8 events over 4 years compared to 1 event. So in absolute terms, even though there's an 8-fold increased risk with intensive treatment of having symptomatic hypotension, that's 8 patients versus 1 patient. In terms of hyperkalemia, defined as above 5.5 millimoles per liter, there was an increased risk, about a 40% relative increased risk. But again, in absolute terms, we're talking about a less than just under 1% absolute increase, again, over the course of 4 years' time in the more intensively compared to the standard treated group, which reflects the utilization of some therapies, of course, on the antihypertensive side that were increased in the intensive treated group. So really not much in terms of adverse events expected, and in absolute terms, definitely nothing big time, I would argue, to worry about in the context of, for example, a significant reduction in stroke and the primary outcome itself. So if we go to the Canadian guidelines, and I pulled this off the website because the guidelines have not been updated, I don't think, in print since 2020, but one of the key recommendations around by Hypertension Canada, the treatment of hypertension in patients who have diabetes mellitus, is that the threshold should be less than 130, at least systolic. This is in part based on the ACCORD study, but it was overall a neutral study, and extrapolating from some of the other trials, but not the most recent studies, for example, in 2024, including, of course, this trial, the BP Road trial. So I'm not a hypertension expert, but looking at this very impressive study, and the subgroup, for example, from the ASPRE study that had over 4,300 type 2 diabetes patients, there's great consistency in these two trials that regardless of diabetes status, for starters, one should really target a systolic blood pressure below 120. And I would argue now with BP Road and the diabetes subgroup of the 2024 published ASPRE trial, including diabetes patients, I think we should be aiming for, regardless of diabetes status, we should be aiming for a systolic blood pressure in our at-risk patients below 120 millimeters of mercury. So coming back to this particular patient case that I outlined, I think going forward, I think this is adds to the ASPRE study and should be practice changing for those who have, for example, type 2 diabetes and hypertension. Just as an aside, with respect to the sort of recommendations around how would you intensify treatment in this individual, it's probably best to consider next a dihydropiene calcium channel blocker, a CCB. And this patient, I've noted, has type 2 diabetes, has coronary disease, has obesity. And so while this is not directly likely to have a major impact on their systolic blood pressure, I think this patient should also be considered for a GLP-1 receptor agonist, based on some of the data that I've shared with you. I think it was in the summertime when I went over some of the highlights from some previous scientific sessions. All right. So now shifting gears, the next case is going to introduce a patient who's had 2 previous myocardial infarctions 2 and 5 years ago, has had 1 year ago an elective PCI to the proximal circumflex for angina, is currently asymptomatic from a cardiovascular standpoint, has relatively preserved left ventricular ejection fraction, has hypertension, which is reasonably managed on treatment, has dyslipidemia, which again on treatment achieves guideline recommended thresholds below LDL of 1.4 and triglycerides below 1.5. It was a previous cigarette smoker, but did quit at the time of the most recent myocardial infarction, and whose high sensitivity C-reactive protein is above 2 at 3.8 milligrams per liter. And so the question is, as this individual's come to the office now a year post-elective PCI, and presumably the dual antiplatelet therapy of aspirin and a P2Y12 receptor inhibitor will be reconsidered. The question is, what additional, if any, secondary prevention therapy would you prescribe? So maybe do nothing, maybe add colchicine, low dose, maybe take the patient off of aspirin or continue on aspirin, and continue a P2Y12 receptor inhibitor, or perhaps maintain the aspirin, stop the P2Y12 receptor inhibitor, and add rivaroxaban a la the COMPASS trial. So this patient obviously has systemic inflammation as indicated by the elevated CRP, and I just want to remind everybody that while the focus has been on atherogenic lipoproteins like LDL cholesterol over the last few decades, appropriately so, reminder that atherosclerosis is actually an inflammatory disease, and the reason that atherosclerotic plaques form, including with, let's say, oxidized LDL cholesterol and other atherogenic lipoproteins in the wall of, for example, the coronary arteries, is because there's endothelial dysfunction because of inflammation and then eventual lipid accumulation. And Paul Ridker would remind us that the typical patient with cardiovascular disease who has elevated LDL cholesterol may have mild elevation of triglycerides and has systemic inflammation as indicated by an elevated CRP. We clearly want to start with high-intensity statin therapy. And if there's residual LDL cholesterol-related risk, despite being on maximally tolerated statin therapy, we have some excellent non-statin treatments that we can add to the mix, like a cholesterol absorption inhibitor, ezetimibe, like PCSK9 inhibition, that shows that further lowering of LDL cholesterol and that residual LDL cholesterol-related risk can also translate into a reduction in cardiovascular events. But as Paul Ridker reminds us, for every one of those patients, we have 3 other patients whose LDL cholesterol might be adequately addressed by the high-intensity statin, but still has residual inflammatory risk, potentially identified by elevation of the triglycerides and certainly the high-sensitivity CRP. And so there are a couple of trials, Colcott and Ledoco-2, that we've discussed in this forum previously, that have demonstrated that low-dose colchicine, 0.5 milligrams daily, can reduce at least non-fatal cardiovascular events. And so this concept that the artery is aflame, and that elevation of or inflammation in the walls of the artery, similar to inflammation in joints, can lead to things like cholesterol crystals and other things that would lead to adverse outcomes from a cardiovascular perspective. And so colchicine has an ancient history. It's been used for thousands of years to treat inflammatory diseases. And from the corm-like bulbs, one can get colchicine, and in low dose included, this can interfere with in particular, the NLRP3 inflammasome, and have and exert an anti-inflammatory effect that can take a patient who might have elevated CRP, for example, and dial that down, again, with low-dose colchicine. As I've mentioned, we've got two trials, the COLCOT study that looked at just under 5,000 patients with a recent myocardial infarction on the left-hand panel, and the LODOCO-2 study in 5,500 patients with chronic coronary syndromes, including more remote myocardial infarction. And we see that in both cases, colchicine significantly, compared to placebo, reduced the primary composite outcomes that are listed on the y-axis there of major adverse cardiovascular events. This is a representative meta-analysis that includes the COLCOT and the LODOCO-2 trial, looks at the other smaller trials of low-dose colchicine, and makes the argument, and this is in a diagrammatic form, but makes the argument that there is significantly less myocardial infarction, significantly less stroke, significantly less coronary revascularization, and a numeric but not significantly lower risk for cardiovascular mortality with low-dose colchicine. And in August of 2021, this particular extended release 0.5 milligram form got Health Canada approval for the use in patients who have coronary artery disease, atherosclerotic event reduction with this therapy as the indication. It did not successfully get public coverage, but it's a relatively inexpensive therapy at 50 cents a day, which contrasts with the 0.6 milligrams of generic colchicine, which is about 20 cents per day and change. Interestingly, in June of 2023, based on the COLCOT and LODOCO-2 trials that I shared with you, there was an indication from the FDA, the first anti-inflammatory therapy in cardiovascular disease that had an indication to reduce cardiovascular events. A similar 0.5 milligram tablet that's available in the United States. However, 2024 has not been as kind to colchicine. There are a number of trials that have come out. This is based on some recent stroke data to suggest that colchicine, at least in secondary prevention of stroke, might not be as favorable as what was seen in the coronary artery disease side of it. And we have a couple of simultaneous publications earlier this year related to a neurology meeting in the BMJ and Lancet, the CHANCE-3 trial that showed no value in patients who had minor to moderate ischemic stroke or TIA and an elevated CRP with respect to the use of colchicine. They initially used 0.5 twice daily for the first 1 to 3 days before dropping down to the dose that was used in the cardiology coronary artery disease-based trials that I shared with you already, 0.5 milligrams daily. On the right-hand side, a little bit more numerically favorable potential outcome with colchicine compared to usual care, again in a smaller patient population who are 40 years of age or older and had at least non-severe stroke or high-risk TIA, but again did not achieve conventional statistical significance. And then right before the AHA, Sanjeet Jolly and the Clear Synergy Oasis 9 investigators presented a part of their 2x2 factorial design, the colchicine results in this post-myocardial or perimyocardial infarction patient population, suggesting that colchicine did not improve outcomes in patients getting PCI after acute myocardial infarction. So here, based on the design paper that's been previously published, is the outline of the 2x2 factorial design. I'm going to share with you both the colchicine results that were presented at the TCT, and then the spironolactone results of the 2x2 factorial that were presented, and then both the colchicine and the spironolactone papers were simultaneously published, coincident with the AHA spironolactone presentation by Sanjeet. So this is 7,000 patients with acute myocardial infarction who were referred for PCI. Initially, the trial was focusing exclusively on STEMI, but they did an amendment in April of 2020 to allow high-risk non-STEMI individuals into the trial. Despite that, you can see at the end of the trial, it's predominantly a STEMI patient population managed with PCI. So 95% of the patients, of the 7,000 patients, have had acute ST segment elevation MI. The Synergy stent, which gives part of the Clear Synergy trial. Its name was a drug-eluting stent with a bioabsorbable polymer, and the data on the sort of 1,000 patients in the registry part of this study has already been published to suggest that that's a decent stent that was recommended for use when any of these patients were undergoing a PCI, including primary PCI. So then within 72 hours of their MI presentation and their PCI, they were randomized in the 2x2 factorial to colchicine or placebo, and then spironolactone or placebo. Focusing on the colchicine, initially this trial was using 0.5 milligrams twice daily, so double the dose of what was used in Colcott and Ledoco 2, for those who at least who are 70 kilograms or greater body weight. And then once the Colcott trial results came out, because this trial started before Colcott and started before we had the Ledoco 2 trial results, they ended up reducing the dose, the randomized colchicine dose, to 0.5 for all patients, regardless of body weight, once daily. If patients developed diarrhea, then the physician could reduce the colchicine or matching placebo. They obviously, in a double-blind fashion, did not know, nor did the patients, what they were taking, to either a half tablet daily or one tablet every other day. And I mention this because you'll see that there is an increased risk of diarrhea as reported by the patients that probably contributed substantially to the adherence of all study medications in this trial. And that contrasts with the previous trials where the 0.5 milligrams once daily did not, in a double-blind fashion, lead to an increase in GI side effects. So a contrast here, maybe in part because of the doses, maybe in part because this straddled the pandemic, where lots of symptoms may lead to less adherence to double-blind study therapy. So the original primary outcome for colchicine versus placebo was the composite of cardiovascular death, MI, and stroke. The event rate was less than they anticipated, and so by September 2023, there was a formal amendment to try to maintain the estimated relative risk reduction that they were looking for. So they increased the sample size and they increased their number of events as part of the primary composite outcome to include ischemia-driven revascularization. So this was an international trial with great leadership, of course, from McMaster and from Canada. And I want to acknowledge, including Dr. Graham here at St. Michael's, the participation of St. Mike's and many other centers across Canada enrolling into the trial. I won't go through the details of these three boxes in terms of some of the selected baseline characteristics. Some of the initial PCI attempts, 3% ended up undergoing CABG, and then the far right table looks at concomitant therapy. But I'll suffice to say by saying that this was mainly a STEMI patient population who are youngish, 61 years of age, and they were very well treated with both revascularization and with medical therapy. In that context, we can see now that the primary outcome showed really no difference between colchicine in red and colchicine placebo in blue, with a median follow-up of 3 years. Now, this was, as Dr. Jolie repeatedly pointed out, the largest trial in terms of outcomes, with almost 650 primary outcome events. And you can see here in the right-hand table the top line, of course, was the primary outcome, but also some of the individual components, and really not much to say in favor of colchicine compared to placebo, which again contrasts somewhat with the Colcott and Ledoco 2 trials. The one difference, perhaps, is there has been some question, and I'll come back to this, about non-cardiovascular mortality. I mentioned earlier that in meta-analyses, there is a numeric but not significant reduction in cardiovascular death. They saw no difference here in the colchicine versus placebo comparison in Clear Synergy. But in the other trials, there was a numeric reduction in cardiovascular death, similar all-cause mortality, but numerically in the other trials, an increase in non-cardiovascular death. Well, one thing that I think that the Clear Synergy study solidifies is there's no increase in non-cardiovascular mortality. In fact, there's actually a statistically significant lowering of non-cardiovascular death with colchicine compared to placebo. This is probably just a chance finding in terms of the statistical significance in favor of colchicine, but at least we could make the argument that non-cardiovascular death with low-dose colchicine is not increased when we pool all of the information together. In terms of adverse events, I've already hinted at the main difference between colchicine and placebo. In this trial, which again contrasts with the other studies, there was more diarrhea, and this led to, in part, much more study drug discontinuation over the course of time. So my bottom line here is, besides why men shouldn't do the dishes, is that we should not throw the baby out with the bathwater. This was an excellent run trial. But we have some differences in terms of the different clinical trials and some of the outcomes. And the fact that this was the largest trial, I don't think negates the potential non-fatal cardiovascular outcome benefit in some selected patients with colchicine compared to placebo. I suspect that the reason why there is absolutely no difference here with colchicine in part relates to the high rates of study drug discontinuation, and the fact that over the time of the pandemic, there was probably even less adherence than we can actually capture here with the colchicine and subsequently, as I'll show you, the spironolactone dosing. So remember, in this 2x2 factorial, patients are taking 2 quote-unquote experimental double-blind therapies, and so we have no measure of adherence. That's not a criticism of the investigators. All we know is that there's a high rate of study drug discontinuation, but that's probably a big underestimate of how many people actually did not regularly adhere to their therapy. And so I suspect that there may be some benefit, again, in some individuals. I think this is a very important information, again, that non-cardiovascular mortality overall does not appear to be increased. There's really no difference in colchicine versus placebo. So hopefully those who are concerned with low-dose colchicine about non-cardiovascular mortality, even though it's been used for thousands of years and used in 4 years in people who have gout and on a chronic basis for familiar Mediterranean fever, without any increased risk in mortality. At least this sort of rests, hopefully puts to rest any concerns about fatality going in the wrong way. The other reason why I don't think we should necessarily throw everything out is that there are a number of other trials besides the Colcott, Ledoco 2, and Clear Synergy studies that are ongoing that will give us additional power are to look at these particular patients and those, for example, who have elevated CRP, which was not a requirement for any of the outcome trials that I just mentioned to you, with the exception of one of the stroke trials. And so I would continue to advocate for the use of colchicine in the so-called frequent flyers, as Paul Ridker has written in this editorial, and make the case that particularly if people have elevation of CRP and you've managed all their other residual risk factors like the triglyceride level, potentially using icosapent pentethyl if their triglycerides are above 1.5, lowering LDL cholesterol below 1.8 millimoles per liter, using one or two antithrombotic therapies. So if you're doing all the right things, like we were trying to do in this patient case that I gave you, and yet the patient still has elevation of their CRP, I think adding colchicine 0.5 milligrams daily will likely exert some non-fatal cardiovascular outcome benefit in individuals like this. Okay, so the last trial, or part of the trials that was presented, that I think is important to go over, and here's the case scenario, is an individual who has an anterior ST segment elevation myocardial infarction and has diffuse coronary disease, is class 1, has left ventricular ejection fraction certainly above 35-40% at 45%, is being treated with appropriate therapy. The question is, should we be adding anything else, for example, an ACE inhibitor or an ARB, a neprilysin inhibitor here, sacubitril/valsartan, an MRA, or even though it's not technically a RAS inhibitor, an SGLT2 inhibitor. So Sanjeet presented at the AHA the other factorial results, the spironolactone part of the design. Quickly, the background to remind you, because I think this is often forgotten, that all comers with myocardial infarction, there is a benefit of utilizing ACE inhibition up front, including with a mortality reduction in all comers. When you look at some of the other trials, with the exception of the Consensus 2 study that I'll remind you was the right drug, but in the wrong scenario, which was IV enalaprilat, followed by enalapril, this made some patients hypotensive. But apart from that particular situation, all the other trial data, it shows a favorable, modest, but statistically significant reduction in all-cause mortality with the use of ACE inhibitor therapy. We know in patients with heart failure, even remote from myocardial infarction, spironolactone, another repurposed drug here, can lead to a significant reduction in, for example, mortality, better event-free survival, including mortality, with the addition of spironolactone on top of other therapy in patients who have severe heart failure and reduced ejection fraction. And then in the early 2000s, Bert Pitt and others showed us that an MRA, in this case eplerenone, when targeting post-MI patients who had reduced ejection fraction and either heart failure or diabetes, on the backdrop of already using ACE or ARB therapy and other secondary prevention therapies, there was a reduction, including in all-cause mortality, with MRA, with eplerenone. What's been unclear is whether we should be using an MRA more broadly, not just targeting those with reduced ejection fraction, but all comers with myocardial infarction. On the left-hand panel, the reminder study was not powered to look at cardiovascular outcome, and it did include all comers with myocardial infarction without a clinical diagnosis of heart failure within the first 24 hours, and showed a numeric reduction in cardiovascular events, but a relatively modest sample size. And then the same study group on the right-hand side did the Albatross study, this time with an MRA regimen, originally an IV bolus of an effective MRA, potassium canrenoate, followed by spironolactone, compared to sort of standard therapy in acute STEMI or high-risk non-STEMI patients, again, regardless of their heart failure or LV systolic dysfunction status. They really didn't see much difference between the MRA regimen and standard care. But in a meta-analysis, individual patient meta-analysis of those two modest sample size trials, there was a suggestion that there may be a mortality advantage, including a reduction in death and resuscitated sudden cardiac death. So it's with that backdrop that Sanjeet and the Clear Synergy team looked at spironolactone 25 milligrams once daily compared to placebo in this mainly STEMI patient population that was being revascularized predominantly with PCI. The co-primary outcomes for spironolactone were two. One was a total composite, so all events of cardiovascular death or new and worsening heart failure. And then in December 2023, again, because the event rate, the blinded event rate was lower than anticipated, they added this second co-primary outcome, cardiovascular death, recurrent myocardial infarction, stroke, or new worsening heart failure. So here's a look again at the patient population, even distribution between the spironolactone and placebo-treated groups. I've already pointed out in the colchicine arm that this is a younger 60 and change, predominantly STEMI patient population. With respect to heart failure and a location of MI, almost 40% were anterior, but very few people had a prior history of heart failure or presented with heart failure. About 20% had diabetes. A well-treated patient population, but relatively, including use of ACE or ARB, about 80%, but relatively few patients using SGLT2 inhibitor therapy, even though about 18 to 19% had type 2 diabetes. But in fairness, this trial started several years ago, and unfortunately the adoption even in diabetes and certainly in heart failure and post-MI of SGLT2 inhibitors was not at that time very high. So here are the co-primary outcomes. On the left-hand panel, CV death or new or worsening heart failure. On the right-hand side, cardiovascular death, MI, stroke, or new or worsening heart failure. And again, no daylight between a placebo and spironolactone in blue and orange respectively. There was a signal for one component of the primary co-primary outcomes. New or worsening heart failure was numerically lower, depending on whether you use an unadjusted or adjusted hazard ratio. I think we can agree that there is numerically lower and at least a trend, one could argue, towards potential benefit in preventing new or worsening heart failure, although again, very few people in the trial with acute MI had heart failure out of the gate. What's the downside of adding spironolactone? So there was more hyperkalemia. There was numerically more hypotension, including orthostatic hypotension. But arguably, one of the main things was gynecomastia and breast tenderness, again, known side effects related to spironolactone. So Mark Banaka was the commentator after Sanjeet presented this, made a number of good points, including the fact that as you go from the Ephesus study with eplerenone in heart failure MI patients that I mentioned earlier on, and look at the event rates over the course of time, far right set of bars to Clear Synergy, it's getting harder and harder in the clinical trial scenario to potentially show benefits of therapies, even if there are modest benefits, given how low some of the hard outcomes are, the frequency of those hard outcomes. So I would summarize by saying, in terms of the renin-angiotensin-aldosterone system inhibition in acute MI, don't forget that there are early and short-term benefits of ACE inhibition in all comers. So there is a mortality advantage of using at least up front. There does not appear to be a role for routine use in more unselected MI patients of MRA, at least with spironolactone from the Clear Synergy trial. But we do know from earlier MRA use, if you've got a HFrEF situation like Ephesus in acute MI patients, that there is, including a mortality advantage. If you've got an MI patient with heart failure, plus or minus reduced ejection fraction, the Paradise MI study of sacubitril valsartan, which was a head-to-head comparison with ramipril, did suggest that there was potential benefit of ARNI over ramipril. And we showed recently that the MPACT MI study, again in a at-risk or with heart failure patient population early on, there may be some prevention of heart failure events, but overall for the cardiovascular event reduction, we did not see a benefit. But many of these patients, especially if they have diabetes or chronic kidney disease, they will become candidates fairly soon after their myocardial infarction for that therapy. So I would have a low threshold to think about using an SGLT2 inhibitor in an MI patient who has reduced ejection fraction and or heart failure, because they also have other indications for SGLT2 inhibitor therapy. So a reminder that while we will not routinely use MRA or some of the other therapies, don't forget to use an ACE inhibitor or an ARB. All right, so that's in a nutshell some of the key potential practice-changing studies from the AHA. I'm going to stop sharing my slides and encourage you to use the chat function or to take yourself off of mute and to fire away with the questions that you might have. Hope that was of help to everybody. Beth, fire away.
Great talk. Can you hear me now?
Yep,
Great
that's
talk.
better.
I'm
Thank
sorry
you.
I missed the beginning. You can tell me what studies there were. I'll grab it my PDF after. But I know we're trying to say not throw the baby out with the bathwater, but one could argue there's a lot of data suggesting, aside from there are a few individuals, as in Paul Ritker's analysis, it says recurrent events, high CRP, that really we're pushing a rock uphill because we're focused on the first trials, but the aggregate of the trials, what do you say to those who haven't embraced it as strongly as some in attitude? Because I looked at this as more evidence for me to feel comfortable not prescribing in everybody and in certain individuals. And, maybe that's not, something is too good to be true. It usually is from the original trials. So I just wanted your comments on that, because I come in from a slightly different perspective seeing those trials.
No, it's a fantastic point. And just, I should have mentioned that I actually have not been involved in any of the colchicine trials. However, my interpretation has been, to your point, even before this neutral study with low-dose colchicine, my approach has not been for all comers. So I think that Colcott and Ledoco 2, which does suggest a more broad potential approach, I was not utilizing colchicine in that way because, in a way, like you said, pushing a rock uphill. Patients are on a lot of therapies, and there was clearly no mortality benefit, including cardiovascular mortality benefit. So it was really, adding therapy number 5 or 6 to therapies that have mortality reduction in addition to non-fatal event reduction. And I appreciate the pill burden and the potential side effects. And even though the cost isn't great, added cost. So we can't sweep that under the carpet. And so the way that I was using colchicine was, again, as per the case, is not in all comers, but only in those frequent flyers who have recurrent events, who have an elevated CRP, and who I've already done, I've got them on everything else, because I do believe that the inflammatory axis is contributing to the residual risk in our patients. And for now, apart from statin and aspirin, which we've got the patients on already as anti-inflammatories as well, we really, and probably icosapent ethyl, I think exerts a lot of its benefit by anti-inflammatory mechanisms. But if I've got the patient on all those therapies and yet they're still inflamed and they're having recurrent events, I think that this is a reasonable, narrow window of opportunity to tackle that. Now, there are trials, as you well know, and others know, There's the canakinumab study, interleukin-1 beta. That's not commercially available, but did show reduction, including in cardiovascular mortality, but pure sort of anti-inflammatory therapy. There are a number of trials going on, including in the acute MI space, with therapy like ziltivekimab, interleukin-6, and we'll have to see whether a pure anti-inflammatory therapy does the trick. But in the meantime, apart from trying to enroll patients into the randomized trials, I think there's still I'll call it a very niche role for colchicine 0.5 milligrams. But to your point, I would not use it in all comers. And I get that people would be skeptical about even reaching for it at all based on the clear synergy results. Great points that you made. Thanks for raising that, Beth. Just checking the chat function. Thanks, Chi Ming, for the kudos. I barraged you, as always, with a lot of data. Any other comments or questions? Bob?
Yeah. So your very first, I'm applying your very first presentation to later presentations.
Okay.
I've always wondered how ACE inhibitors work to improve things.
Yeah.
And are those previous trials, does ACE work because it lowers blood pressure and we didn't pick it up in previous trials?
Yeah, great question. So the value of, let's say, ACE in all comers in acute MI, unfortunately, none of those, they were large outcome studies, but none of them really had sub-studies. And so in terms of looking at what is the mechanism, they did document blood pressure lowering for sure. We're talking, maybe, and then of course the HOPE trial and others showed on average, there may be as much as a 3 to 4 to 5 systolic over 2 to 3 millimeter diastolic delta compared to placebo. And so I think you're right, Bob. I think some of that acutely in the all-comers with MI is probably a blood pressure lowering effect. I think once you get past that early time window, looking at HOPE and looking at some of the other trials, it's hard to account for the cardiovascular outcome benefits being driven or mostly driven by the reduction in blood pressure alone. So I do believe that there's some blood pressure lowering benefit for all comers, but I suspect that there's other vascular benefits that are coming from inhibition of the renin-angiotensin-aldosterone system that are contributing to the longer term outcome that we're seeing like in the HOPE trial, the PEACE trial, etc. So it's multifactorial, I think. Great. All right. Well, we're at the hour. Once people log out, you should be prompted to go to the evaluation form. It takes like literally 10-15 seconds to complete that. This is rounds that are accredited, so please take a moment of time and give me some feedback as well. Much appreciated. I hope that was of help, and we'll see everybody next week.
Thank you.
Thanks all. Bye now. Thanks, Howard. Thanks, Jiming.